Hi, good evening, everybody. This is Tess Hill. I'm a student in the doctoral program at Maryville University. I am doing my presentation on my scholarly project, which is the importance of proper screening and referral to a behavioral health counselor. Again, my name is Tessaneka Hill. Before I begin with the presentation, I would like to thank my committee chair, Dr. Elby. My community chair is Antonia Jones. Excuse me. So we all know that individuals who suffer from mental illnesses and persons of a lower socioeconomic status oftentimes feel as they have no voice, that they are powerless, they feel less empowered. They have a higher incidence of treatment and medication non-adherence. Because of this, they oftentimes are at increased risk of morbidity, mortality, and unfortunately death. People of a lower socioeconomic status have barriers to accessing health care or quality care for that matter. They oftentimes seek care at more advanced stages of illnesses. So the challenges that they have or the barriers that they have oftentimes is they're either uninsured, underinsured, financially unstable, or just don't have the means or the knowledge to know where to go. And oftentimes you'll see that they just don't trust healthcare providers. So this was kind of near and dear to me. I have been working in an underserved community for most of my nursing career. And so you kind of see the challenges that people have. But review of preliminary data at the facility revealed that 65% of the patients who were seen were not being screened, referred to BHC. Or if they were screened, there was no way to really track if they had followed through with the BHC, with behavioral health counselor. And this led to a lot of people being lost to care, and that's concerning. So to address this problem, a quality improvement project focusing on minority women between the ages of 18 and 40 was initiated. And the reason why I chose minority women is because in the city where I practice, their poverty rate is at 27.2%. Nationally, the poverty rate is like 12%, so it's a high poverty rate. Of that, the majority, the most common group of people and that poverty level are women between the ages of, most common is 25 to 34, followed by between the ages of 34 to 44. So that's the concern for me. The purpose of this quality improvement project was to determine if implementing the patient health questionnaire identified patients who screened positive and increased referrals to BHCs. The PHQ-9 and PHQ-2 are evidence-based tools that are easy to use in primary care. They give you quick results, so you can kind of identify patients who need to be seen more closely or by a BHC. And we know there's a shortage of mental health providers too, so a lot of times primary care physicians are the ones who can identify patients who have challenges. The aims of my project were threefold. One, I want to increase the number of patients who were being screened. 2, increase the number of patients who were being referred to a BHC. And 3, increase the number of patients who were actually seen by the BHC. So just because we referred to a BHC, again, like I stated, there was no way to track whether or not the BHC actually met with the individual. So I actually wanted to see the impact, or explore the impact that a BHC will have on patient compliance and healthcare outcomes. So again, just trying to partner with a BHC and seeing what challenges the patient may be faced with. I use a retrospective chart review to analyze the impact of the intervention. It was a quantitative exploratory design. I created a data instrument sheet to capture the data pre and post assessment. The responses were nominal, and it was either yes or no. The data was then transcribed on a data collection tool and evaluated. Evaluated after the study was completed. Well, before and after the study was completed. This is actually an example of the data collection tool that I had used. Not sure if you can see, but it just clearly just was asked if the patient to a screen were they referred to a BHC, were they seen by a BHC, and that was pre and post. Excuse me. So there was a total of 160 charts that were reviewed, pre and post data. So I looked at data starting in like November to February, and then March to June to capture that data. So it was 6 months of data. 6 month time period that I was looking at. And we all know statistically it's very important to have an adequate sample size to allow for appropriate study design. So after meeting with the statistician, he guided me in the right direction and made sure that I had enough ample sample size for my study. Again, the data that I captured was from an electronic medical record. It was extracted data. I will receive a list of individuals from the quality department, as well as director of behavioral health counselor at the facility. They were all, the leadership team really was very, very supportive of the project, and I think they're all looking to see how we can best help the patient. So again, I utilized the EMR to capture the data. As I stated, the racial and ethnic background for the project was 73% African American women, 9.4% of Hispanics. I think the 18.1% were a combination of Asian and Pacific Islanders. This is just a pie chart of the ethnic makeup of the individuals in the study. And this is the information pre-intervention. As you can see, the purple depicts patients who either did not keep their follow-up appointment, they missed an appointment, they were not seen by a BHC, or they were not referred to a BHC. The red depicts if the patient kept the follow-up appointment, if they showed up for an appointment, if they were actually seen by a BHC, or if they were referred to a BHC. And as you can see, post-intervention, there were significant improvements. I was actually very proud of this study. The red depicts, again, the people who, or the patients who did not keep a follow-up appointment, who missed an appointment, who were not seen by a BHC. And the blue is the individuals who kept their appointments, who kept the follow-up appointments, who did not miss the appointment, and who were referred to. And as you can see, with intervention, we had most of the people were actually referred to a BHC. And we had documented that they were, we could track that. Excuse me. I used a paired t-test to determine the differences between the patients who have been referred to and met with a BHC versus those who had not. Again, like I said, I was very proud of the study. Excuse me. Because there was statistical significance in the outcome. So again, I believe we had post intervention. There were like 93% of patients who actually kept their follow-up appointments and met with the BHC versus those who had not. The next few slides are just going to talk to my statistics, the data. So as you can see, the confidence interval is 95%, which is good. This is the power analysis, and again, as you can see, it's actually really a good study. I'm really proud of the impact that the project has had. And this is essentially, again, like I said, the upper tail for the z-test. And you see my sample size here, and the number of items of interest, which is really good. It's really quite interesting because, as I stated, I worked in public health for most of my nursing career, and there's always been a struggle and a challenge, but the pandemic has really revealed the healthcare disparities that these people in the community are forced to deal with, their family are forced to deal with. It was quite a challenge. So again, I talked this already about the poverty rate in New Jersey. It's 10.2. The poverty rate in the city of Trenton, though, is 27.2, which is considered really, really high. And we all know, again, poverty, lack of access and resources, and discrimination increase the risk for major depression disorder. You know, it was thought that by 2025 we would be seeing a significant decrease in the number of physicians. That number has now changed because now we're seeing a significant shortage of healthcare providers, and this creates a challenge. So even when I initiated the project, we started doing it. That's kind of at the height of COVID, and so we had to quickly adjust to telemedicine, quickly adjust to having decrease in the number of staff, like nurses, medical assistants. And so I was fortunate enough to have my team with me during that, so we were able to get the data. But you can clearly see the impact that COVID has had. So that's why it's very important that patients are seen, screened, and referred to a BHC because their quality of health kind of improves. Again, I think we all can talk about the challenges of watching and seeing people die from COVID. As healthcare providers, we're generally in the field because we want to prevent deaths. And so you top that on COVID, you had people dying, and the sadder part was that because of the guidance from the CDC, because of the social distance, quarantine, and isolation, that oftentimes when someone went to the hospital, the only person that they had was either the healthcare provider, and those were the last people who would also see them take their last breath. So you can only imagine how traumatic that is for medical providers. And so that's why I think we're seeing such an influx of staff. Like most places are short-staffed in healthcare as well. Again, I kind of talked to this already about the shortage of providers, healthcare providers that we're going to be faced with. I'm just hoping in time it gets better, but that's why it's more and more important to have an integration of your team, because you cannot do this work alone. The Quality Improvement Project, I really wanted to improve health outcomes by increasing the number of patients with a positive PHQ-9 who were referred to and seen by a BHC. Meeting with the BHC actually, had some really good positive results for the patients, because BHCs are social workers by trade. Most of the ones BHCs at the organization that I work at, and they can address other needs such as potential homelessness, food insecurities. If someone could not afford to pay for medications, helping that person get through, enroll with the 340B process. So those were some of the things. Additionally, the BACs have access to other resources through NowPal, which is a portal. They can get resources for patients. So you have patients who were now forced with homelessness because the emergency eviction moratorium had lifted. You had folks faced with their lights about to be turned off. So those were the challenges that the BHCs could help the patient do. And ultimately, I think the BHCs and the project actually help patients get more comfortable and trusting of healthcare providers. So the findings of the study actually spoke to the importance of proper screening and increasing the number of patients with a positive PHQ-9 who were referred to and seen by a BHC, so screened. The results were, pre and post, you clearly see it was actually really great results. And the new, I'm really happy to say that the process has actually been initiated and kind of started. So because we wanted every team to fully understand the process, we're rolling out one site at a time. By employing strategies to help improve, I think, healthcare relationship, I help identify patients who have unmet needs, patients with poverty, patients with food insecurities, patients with homelessness, and partner will ensure that they receive the care they need in a timely fashion. Again, I spoke to this slide already. I'm going ahead of myself. But proper screening referral to BHCs have enormous implications to improve the quality of health of patients. And again, our BHCs are generally the ones that I work with, are social workers by trade. They have access to various resources. Additionally, as a provider, you only have a set amount of time to see patients. You don't have all the time to address everything. Have a BHC on your team could actually lift that weight some too. And so again, you could give the patient a dedicated time to address a medical issue, as well as getting the other social issues that they may have taken care of. Or if they have a depression, anxiety, post-traumatic stress disorder, identifying those mental illnesses and getting them the proper care that they need. The project is definitely going to improve the quality of healthcare policies in the practice, as well as procedures by ensuring that patients are referred to our behavioral health counselor punctually, so we don't have to wait. We won't lose patients through loss to care, which is another term I hate. Identifying high-risk behaviors such as depression, anxiety, post-traumatic stress disorder, and traumas. And speaking of the pandemic, I know I keep going back to the pandemic, but I think it's very important to understand that the challenges that a mother may have had when school shut down, and if the only meal that the child got was from school, you can understand the stresses that parent could have dealt with. So future policy is needed to establish the impact of BHTs on patients' adherence to treatment plans when they are embedded in a medical team, integrated. So the recommendations that I have for the project to continue research, meaning that I think it's very important that we should screen not just adults but all patients at each visit. Importance of educating the staff so they can understand why why screening is so important. And then once you implement something, going back and follow up and asking them if they have any questions. So you want to have an open door policy so staff will be equipped with the knowledge and supportive of the project. So and ultimately for patients, this creates such a patient-centered approach because you're meeting the patients where they are at. Thank you guys so much for listening to the presentation. I apologize, my voice is going, I'm losing my voice, but thank you so much. Again, my name is Tessaneka Hill, Referral University.